Thank you very much. So I'd like to thank Namrata just well for and Rishi for the kind invitation to talk at this meeting. Can you see my slides? Yep. Okay.
Yeah.
So I'm going to be talking about non-cultured endothelial cells, and I'm just going to really describe some concepts for this technique and how we've been working on this over the last few years. These are my financial disclosures. They don't really pertain with what we're going to be talking about today. So we all know that really over the last 10 to 12 years, we've seen a significant shift in the way we perform endothelial surgery, with endothelial keratoplasty becoming the dominant procedure. And you can see this from data from the Eye Bank Association of America on the left, and also in Singapore Corneal Transplantation Database. But really the next evolution, as Shiguru has shown with respect to endothelial cell therapy, is really selective cell therapy. And it's taking this concept forward where we're changing selective individual layers to selecting individual cells. And of course, this is going to it's taken the form already for epithelial work, which we know from several publications. Endothelial work has obviously great promise because obviously we have a lot of patients that require this as well. And I think in the future, we will see keratinocyte cell therapy coming into clinical practice as well. However, one of the issues with any of the cell-based therapy products is that they basically must be cultured within a special lab. So they're therapeutic products itself. So you need basically trained personnel with good culture experience with appropriate expertise. They must be GMP certified labs because these are all therapeutic medicinal products and classified as such. And most authorities will classify these as high-risk projects because the cells are manipulated during the cell culture process. And of course, as the cells are expanded, they basically undergo some sort of manipulation before they're basically put back into the recipient tissue. Therefore, they do require some critical quality attributes in order to verify the cells themselves before they basically go back into the patient. And of course, there's a whole lot of quality risk assessments that must be undertaken before the product per se can be released for clinical use. So most of you will be familiar with Virendra Sangwan's work in LV Prasad, where he described a technique that he basically called SLED. And he basically showed this as sort of a in vivo technique of basically culturing epithelial cells on the surface. And you can see the differences over here from this schematic between CLET, where the cells are cultured outside in vitro and then expanded and basically put back on the ocular surface on a sheet. While with simple limbal epithelial transplantation, you simply take the limbal biopsy, cut it up into smaller pieces, and then basically remove the scar from the ocular surface, place the limbal bits of products over there, hold them down with fibrin glue, and then you can see how it can basically reconstruct the surface. So we thought, is it possible that we could apply some of the same thinkings to this to endothelial basically work? If you look at basically the transplant rate or transplantation using of donor corneas in the US, you'll see that basically, and this is quite consistent amongst many eye banks, that actually only about 70% of all the transplants that are actually harvested are actually used for corneal transplantation. And if you look at this in a little bit more detail, you will see tissue suitability and serological testing are the two reasons, or the highest two reasons, why the tissue is rejected. Now, of course, you can't use the tissues for if they're serologically positive, but you could use this and examine this tissue suitability in a little bit more detail. And in fact, if you look at this tissue suitability in a bit more detail, the number one reason why the tissue is not used is because of problems with the corneal endothelium, or the endothelial cell count is basically too low. So this is the schematic concept of how we can basically use this tissue. So if you take a tissue from a donor cornea, the endothelial cell count is good. Of course, you can use this for basically endothelial surgery. If the tissue is basically less than 45 years old, it could be used for endothelial cell cultures. Professor Kaneshita has showed you can cultivate the cells, and these can be injected basically back in the eye. If it's greater than 45, of course, we can use it for EK surgery, typically DMEG. However, it's diabetic. We know there's a high risk of basically tearing the graft, that there's scars there, or there's something, issues with the cornea or a previous scar that we can't basically peel away the desmoid membrane properly. It is possible to recycle this tissue. Likewise, if we have cell count tissue for less than 2,000, of course, this could be kept for emergency graft. In some situations, it can be used for adult. And in a lot of situations, the tissue is actually disposed away. And the question is that can we recycle this tissue and use this as a cell injection product to basically put inside the eye? And this is something that we thought about a few years back and wanted to see whether this was basically possible. This is from the concept from the paper that we published basically back in 2020, showing you the idea of how this would basically work. And the idea is you take your donor cornea with low endothelial cell count, you strip it, and this is a crucial bit of this whole technique. You need to make the cells into a single suspension before you can basically inject them basically inside the eye. And using a whole series of different cocktails, enzymatic processes that we basically analyze, we're able to make a single suspension. This is simply then injected inside the eye, typically when we do our typical cell injection, basically therapy after the endothelium is basically removed with a 30 gauge cannula. You inject the cells inside the eye, and then the patient or the animal would then be postured down for basically 3 hours as well. So initially when we studied this, we tested a whole series of different enzymes that we could find in the literature to allow us to remove the endothelial cells without actually damaging them and allow us to basically make them as basically a cell-free suspension. And what we found was that using a combination of triple LE select and the right tissue media, we could actually elevate the endothelium from an intact basically descemet's membrane. We would then be able to do some counts to look at how many cells we were basically getting. And you can see the counts vary from about 34,000 all the way up to 126,000 once we got basically a bit more familiar with the technique. And the overall yield we found was better when we put them in a stabilization medium in what we call Endo 5 medium compared to basically a more proliferative medium itself. And when you look at this in real terms, we were getting about a yield of about 50% of the endothelial cells off basically the surface itself. So we thought, okay, the technique is quite reproducible. We're able to get enough endothelial cells. And the question is though, are these endothelial cells functional? So what we did was we injected these basically back into the rabbits. So this is using the same model that we use for cell injection therapy using cultured cells. So the endothelium is basically removed back off the rabbit. So you remove it all with a silicone tip scraper. We then basically test to basically remove the endothelium is being removed with the Trident Blue. These are the cells that come from the lab. So these are all created from a single cell expansion from a donor without any cellular expansion. And then all we do basically simply inject them inside the anterior chamber, and then the rabbits basically posture face down. So if you look at the results, this is basically what we're able to show. We use the control group where we injected the ROCK inhibitor without any cells, and we compared this to our cultured cells, which are the ones that you see in the green line over here itself. And what you can see is that the non-cultured cells over here in the cyan blur, of course, you get a little bit of edema to start with. Then basically by week 1, there's a massive reduction in edema itself. And when you get basically out to week 3, there's no significant difference between our cultured cells versus basically the non-cultured cells themselves. And if you do some staining, you can see the endothelial cell count. Now, the endothelial cell density, of course, will be lowered in the non-cultured cells because we have to replenish the whole of the endothelial surface in the rabbit because we have to remove all the rabbit cells. And you can see that the cells are staining up with basically the green and cyan colors over here, showing you that they're basically human cells. Now, if you look at the donors that we basically use, you'll see that we use a whole variety of donors from the age of 4 up to basically 72 age. Now, of course, you would never take a 4-year-old donor to basically do a DMET. But here, of course, we know 4-year-old donors are going to have excellent endothelial cell counts. So, of course, this could be a use of basically this donor itself. And we took endothelial cell counts as low as basically 1,215, which most people may use for basically dog, but most people will basically throw this tissue away or keep it basically for emergency use as well. Yet we were able to replace the endothelium in our basically disease model. The days to processing the tissue was also long. Bear in mind, these are cold storage tissues in up to 21 days, yet we were able to still rescue the endothelium. Now, taking this forward, obviously, we're thinking about much more with clinical implication, and we're working with the US Eye Bank to make this into clinical practice. The final thing with this is that the key thing is the critical yield over here in this bit over here that goes into the Eppendorf tube, because this will equate to the number of cells that are actually basically injecting. And of course, anybody who can strip the decimase off from the eye bank preparing tissue for DMEC will be able to basically use this technique. And using the enzymatic process is basically very simple. And then you basically undergo filtering itself as well. One of the things we know is that your cell count or your actual cell count of the tissue has no with respect to how many cells you can have. And you can see this from this example over here, where you can see all these donors with cell counts roughly about the same from 2,269 up to about 2,411. But if you look at the amount of cell yield we get, you can see it varies from all the way from 0.49 to 10 to the 5 up to basically 2.38 itself. So obviously this would be a very good donor that we need to basically inject. And we can inject up to about 170,000 cells and still get the system to basically work in our basically rabbit model. Now in a human, because we were scraping off less endothelial basically area, you probably wouldn't even need that many cells in order to basically get a functional system. In order to do the counting, we've been basically using a system called nuclear counter. Now, you cannot take too many cells, because the more cells you take to do the counting, of course, you're going to basically take cells out that could be basically used inside the eye itself. And what we've been doing is using this system, and what we found is that we could use a dilution factor of about 4 times from different donors and still get an accurate level of cell count. So when the Eppendorf tube would come to the surgeon, they would know exactly how many cells are basically in that tube itself by using a dilution gradient of about basically 4 times. And we varied this on our basically cultured cells, and then we repeated this basically using our non-cultured cells itself. And it's pretty accurate with respect to the dilution coefficient between basically 25 up to 32.3% accuracy compared to the undiluted endothelial cells. So now we have a way of definitively telling the surgeon, this is how many cells are in that Eppendorf tube that you're going to basically inject into the patient. How can you prove that these are basically non-manipulated cells? Well, this is very simple. You basically look at the cell cycle using the same machine. We're able to show that between 93 and up to 97.3% of the cells in that basically non-culture technique are basically in the G1 phase, which is the most common phase that you'll see most basically endothelial cells. So truly these cells are non-manipulated. And the key advantage of this is that means the regulatory approvals are much less stringent compared to higher risk manipulated basically cells themselves. And when we basically recently, over the last 6 months, been injecting these cells using a GMP grade ROCK inhibitor, you can see the results between the cultured cells and the non-cultured cells using a GMP ROCK inhibitor are almost exactly the same when you basically follow these out basically to 3 weeks. The ones in the red line over here are the ones using Y27632, which is from our original paper, and the control group over here in the blue. So we can replicate the analysis with a GMP grade ROCK inhibitor, which obviously is crucial to allow this to go into a clinical trial. So in summary, over the last 2 decades, the emergence of selective tissue transplantation in the form of ALK and EK has changed the face of corneal transplantation. This has led to better vision, faster rehabilitation, less intraoperative and postoperative complications, and lower rejection rates. The next evolution is truly selective cell therapy. All cell expansion therapy techniques need to be managed as advanced therapeutic medicinal products in a high-risk category with respect to regulation. However, there is a significant amount of corneal tissue that is harvested that is not used for transplantation due to low endothelial cell counts. And likewise, there is tissue with good endothelial cell counts that cannot be used for endothelial cell injection therapy that can be basically recycled as well. The non-culture technique that I've shown you is a simple, minimally manipulated technique, and we have shown it to be effective to rescue bullous keratopathy in animal models. We are recently basically QCing this whole process in order to prepare basically for a clinical trial. I just wanted to acknowledge my team in Singapore and thank you for your attention.
Excellent lecture, Dr. Jodbir. Any comments, Dr. Ritu Arora?
I think we're all into new phase and completely zapped, so you don't need all those techniques for culturing, and if you can give good results, definitely very better.
So I think, Jodbir, what you're saying is not culturing is going to be the next style of endothelial cell transplantation.
Well, no, I think that you'll see that obviously cultured cells allows us to treat the world's shortage of transplantation, right? There's no question, because as Guru said, you can expand and treat 100 patients from basically one donor, right? So that's going to tackle our social issues worldwide, because we go to many countries, right, where there's not enough endothelial tissue. What I'm showing is that we already we can use a system where we don't have to culture the cells in the tissue that other people are actually throwing away and still use it for endothelial rescue. So I think these two things are basically synergistic and will go hand in hand, hopefully.
Hi, Jod. It was really good to hear you again. I just would like to know what determines your dilution factor and what's the ideal dilution factor for your injectable endothelial cells. And number two, what I'd like to know is, I'm sure you're using ROCK inhibitors in these cases. And there has been a concern about ROCK inhibitors that these cause microcystic changes in the corneal epithelium. So is there a particular trend that we need to know that which patients can be more prone to this particular incidence using? And how long are you using them?
No, so the ROCK inhibitor is only used once at the time of cell injection in the vial that we inject. They're not used post-operatively. So there's no issue with respect to epithelial toxicity from that way. With respect to the concentration, generally we inject into a volume of we use 150 microliter volume. And in the animals, we inject we definitely going to get it, we definitely be able to get it to show to work with about 170,000 cells. Now, the thing is, you got to bear in mind that in a rabbit, you have to remove the whole of the endothelium, which is almost 12 millimeter white to white from the inside surface itself. Now, in a human, you wouldn't have to do that because you just need to clear the central 8 millimeters to inject that number of cells itself. And that would then allow us to work out how many cells would be the minimum cutoff. So if you're harvesting a donor tissue, say of 1,500 cells, and most people would probably keep that maybe frozen for a tectonic graft. They certainly would never use it for EK surgery. It's possible using this technique. All you have to be able to do is learn how to strip off the Descemet's membrane, which, to be frank, most people can do now quite well thanks to basically DMEC. And then you follow that enzymatic protocol. The enzymatic protocol actually is all GMP grade. It's quite simple to basically follow itself, and then you use the filter. The dilution effect is to work out the concentration so you don't remove too many cells. Because when we were discussing this, I said, look, every surgeon's going to want to know how many cells are in that Eppendorf tube. Otherwise, because you can't see it, right? I mean, you can see it in the video I showed, but that's because we stained it green, but you actually can't see them. When the girls give it to me to inject, I can't see anything, to be frank. And I said that every surgeon needs to know in that suspension how many cells there are. And this is a very simple machine, actually. It's not that expensive at all to actually basically be able to take out 4 times dilution, and you can pretty well accurately tell how many cells you have.
Yeah, thank you, Jod. Real exciting times ahead, I guess. Thank you.
Thank you.
So our next keynote address is by Dr. Vishal Jhaji, who will be speaking on recalcitrant bacterial keratitis. Over to you, Dr. Vishal.
Thank you very much. Can you see my slides?
Yes.
All right. So this is going to be a different kind of culture. So I want to thank everybody, especially Dr. Namrata Sharma, for inviting me to this summit, and of course all the panelists, some of who are my teachers. And the presentation, the content, the principles most of them I learned from them over the past 20 years or so.